Okay, so welcome to the April 2024 GMA Global Emergency Medicine Fellowship Consortium Didactic. And today we're going to be joined by Dr. Adam Levine, who is a professor of emergency medicine and health services policy and practice at Brown University. Adam also serves as the Associate Dean for Global Health Equity and is a director of the Center for Humanitarian Rights and Humanitarian Studies at Brown University. He is a medical doctor from the University of California, San Francisco, and has an MPH from University of California, Berkeley, before completing specialty training in emergency medicine and humanitarian studies at Harvard University. I've had the pleasure of knowing Dr. Levine for about 10, 12 years. He has done this very interesting career path at the intersection of humanitarian health and research, which truly is the most challenging thing to do. When all of us as emergency medicine hear about a disaster, we just want to jump in feet first. That is kind of a part of our, bread and butter. Actually, I was driving in today and there was a car crash in front of me and a bunch of people drove past it. And I put my car in hazards and checked to see if the other person was okay. That's just what everybody in this call would do. But the challenge is between the storms, there's periods of quiet. And there's opportunities in those periods of quiet to understand how to improve response mechanisms, preparedness mechanisms, but also to research. Again, we talk a lot in this series about how to have a career that is sustainable and funded. And this is one of those avenues. So I'm going to hand over to Dr. Levine to guide us through the next 40 to 45 minutes to talk about the role of research in humanitarian response. Thanks, Adam.
Thank you so much. It's great to be talking with all of you. So as Bhakti was mentioning, I'm an emergency physician by training and started my career working in the field with a number of humanitarian agencies, in addition to working clinically here in Rhode Island at Brown University. I worked with International Medical Corps, a little bit with Doctors Without Borders or MSF, with Partners in Health, and also with the International Center for Diarrheal Disease Research in Bangladesh. And, during these emergencies, I responded to disasters such as the earthquake in Haiti in 2010, to civil war such as in Libya in 2011 and in South Sudan in 2012. And then different cholera epidemics from Haiti to Bangladesh, the Ebola epidemic in West Africa, in Liberia and Sierra Leone, and then later the Ebola epidemic in DR Congo. And of course, along with everyone else, the COVID-19 pandemic worldwide. As I was working in a lot of these humanitarian emergencies early in my career, which is, really what I was really excited to do. I got special training in residency at Harvard in humanitarian months, and I was, excited to be doing that work. And it was very fulfilling and it was good work in many ways. But as I was doing it, I started to realize that humanitarian response today is a lot like medicine 50 years ago, based mostly on anecdote rather than evidence, with very little in the way of training, sort of doctors being thrown out of medical school into the hospital wards and the emergency room to just work without any specialized training to be able to do it. Similarly, people were just kind of thrown, doctors were thrown, nurses, engineers, technicians, public health specialists were just thrown into the humanitarian world without any sort of professional training to ensure that they actually had the skills to work in that specific setting. All of us in emergency medicine know that not just anybody can walk into an ER and work there. You actually need a residency, you need specialized training to be able to do that. And it's not enough to just have sort of all of the literature from our colleagues in, trauma surgery and cardiology and OB-GYN. We need our own literature in order to inform best practices in that setting. And it's similarly true, I realize, with humanitarian health, that there is a need for an evidence base to ensure that all the good work we were trying to do actually did good for people, instead of just making us feel better. And honestly, without evidence, you never really know whether the work that you're trying to do, whether your intentions are actually resulting in the outcomes that you would like. Also, without evidence, you don't really know what the populations you're serving actually want. If you're not actually talking to them, collecting data from them, you're only thinking that what you would want in that setting or what you think they should want. You're not thinking about what they actually want. And so that, in addition to sort of, more clinical trial-based research, the need for good qualitative research to really understand the needs from the perspective of affected communities who are affected by disaster and war, became, very imperative for me. And so I started partnering with a lot of the same humanitarian organizations that I had volunteered with in the field, but this time to apply for grants from the federal government, from foundations, in order to conduct research in these settings, in order to develop specific training programs, professional training programs for humanitarian aid workers, and especially for humanitarian aid workers from the Global South, since they are the ones who provide the vast majority of humanitarian assistance. More than 90% of humanitarian aid workers are from the country where the emergency is happening, even if they're working for an international NGO like Doctors Without Borders or International Medical Corps. And so they're the ones who need the most training in terms of how to work in a humanitarian setting, but also training of expats as well. So I'm going to just go through this talk, conducting research in humanitarian emergencies, try and squeeze it into the hour, and happy to answer questions that you guys have along the way. It's a small group, so you can feel free to just ask questions. Another way of titling this talk is Ebola 4 Ways, which is sort of a funny way of me saying how my research in one specific type of public health emergency, Ebola, has developed over the past decade, and different methods of doing research in humanitarian settings, which brings to light the importance of not having just one approach, of being able to look at problems from a lot of different perspectives, which means different disciplinary approaches when it comes to doing research in humanitarian settings. So I guess the first question, and I've talked a little bit about this already, but I would just love to hear your thoughts, going into this talk. Why do research in humanitarian emergencies? This is a picture from Haiti that I took in 2010 when I was there after the earthquake. You might think that this is not the right place to do research, and also not the right time to do research. People have real needs. Their homes have been destroyed. There's a lack of healthcare and medical care available. Why would you choose this time and moment to do research? Any thoughts? Feel free to throw in the chat or just speak up.
I mean, you need to know if you're making any sort of useful impact or if people actually need the help you're able to provide.
Right. So understanding whether what you're trying to do is impactful. And honestly, the research you're doing right now in the Haiti earthquake is not going to help people in Haiti during this earthquake, but it may be helpful in a future earthquake in Haiti or somewhere else. And it may help humanitarians actually be able to provide better care in that sort of setting. Other thoughts?
This is likely a really high impact setting where simple interventions could really save a lot of lives if thoughtfully advocated for.
Right. And, another way of saying that is that, there are a lot of really cost-effective interventions that can save a lot of lives in these areas if we know which ones are most cost-effective. There is a limited amount of funding right now for humanitarian assistance in the world. We spend, almost $50 billion a year on humanitarian assistance, which might seem like a lot, but I've been told that that's about what the world spends on chewing gum each year. So in totality, it's really not that much to respond to all the different emergencies going on around the world that we all know about. And so there's a need to make sure that that money is spent as well as possible and translates into as many saved lives and reduced suffering as possible. And so we can only do that by having evidence to inform which interventions work better than others and which interventions are more cost-effective than others. And then we have a comment. It's a rare opportunity to gather an understanding of the needs in these settings, which can help with disaster preparedness and future emergencies. And that's right too. Like, whether it be this emergency or the next one, understanding what people on the ground feel is their most pressing need is going to be really important in ensuring that they feel like the response has actually been helpful to them, which at the end of the day is really kind of one of the most important things that we want to accomplish. So hopefully maybe you're convinced that research in humanitarian emergencies is important, but I don't want to sugarcoat it. There are serious challenges to conducting research in humanitarian settings, which is why so few people do it. And, I know a lot of them, but there's a cadre of maybe a few hundred people in the world who do research in humanitarian settings, and there are a growing number every day. But part of the reason that there's so few of them is because of all these challenges. And I'll just go through quickly because I want to focus this more on the actual work than the challenges, but here are them in no particular order. So challenge one is funding. So there are few agencies that provide funding specifically for research in humanitarian crises, though there aren't zero. So Research for Health and Humanitarian Crises, which is a UK-based fund. I'm on their funding committee, actually. They are one of the few that have an explicit interest in providing funding for research in humanitarian crises. And then a number of the big funding agencies will occasionally have calls. But in general, there's very little funding specifically for this area. There's conflicting timeframes between a grant funding cycle and a humanitarian response cycle. So a disaster, especially an acute onset disaster, occurs. It's not helpful then if you apply for a grant even the next day, because you're not going to get it until a year later. And by that time, the emergency is over. And so there is going to be this real mismatch between the grant funding and your ability to actually carry out the research. There's challenges to spending money in crisis locations, even if you have the grant funding. Being able to hire staff, being able to buy supplies, being able to transport supplies or staff into a humanitarian setting can be very difficult, especially when the banks aren't working or shut down. And then accessing research funding is particularly difficult for local researchers in areas affected by crisis. In many ways, a local researcher based at a university in the setting where the crisis is occurring is best positioned to actually carry out a research study because they already have probably contacts and connections and staff on the ground. They have an understanding of how to carry out the work, but they have the least ability to access research funding for humanitarian emergencies. There are very specific ethical challenges. Of course, there are many ethical challenges to research in general, but there are specific ones that affect humanitarian research. Again, this time frame, so it can take several months to get IRB approval. By that time, the acute phase of an emergency might be over. And so being able to actually get approval in time to carry out a research study in a humanitarian crisis can be incredibly difficult. And that's assuming that there is a local body able to provide ethical approval. It probably has shut down along with most of the other functions of government or civil society in the aftermath of the conflict or the disaster. And so you may not even be able to find one that's operational that you can apply to. There are language and cultural barriers, which is true of all global health research, staff training and incentive issues. Being able to hire local staff that have the training to conduct research can be difficult. And the incentives, for instance, if you're doing a clinical study and you're hiring nurses or doctors to be your research staff, those are nurses or doctors who would otherwise probably be responding to the crisis. And so to what extent are you actually taking away from the humanitarian response by hiring these staff? And then issues around patient incentives and lack of alternative care options. Consent may not be as meaningful if you are the only provider of care or the only reasonable place that a person can get care, and they feel that it's important to participate in the study in order to get that care. There are extreme logistical challenges, as you can imagine. Number one being security. So whether it's a disaster or a conflict situation, and ensuring the security of your research staff is fundamental. There are going to be issues of geography and weather, roads and supply chains, which, as we know from the pandemic, supply chains often break down in the setting of emergencies, network and internet connections, local laws and regulations around things like consent and ethical approval and hiring and firing staff are all going to be different. Issues around language and translation, which are going to be similar in many global health settings. And then, of course, the problem of adequate human resources. And then if you get through all of the work and actually complete the research, there are important questions around dissemination. Local versus global dissemination. Are you actually trying to get the results back to the community that's affected by the humanitarian crisis, or are you working to disseminate it more globally to a global humanitarian audience? Are you disseminating it to an academic audience or a policy audience? Because I promise they don't read the same journals. And it may be the policy audience that's more likely to be able to affect future interventions and especially funding for humanitarian crises. Are you trying to get this published rapidly so you can affect care in the actual crisis you're in, which basically means putting it up on a website, right? Or are you trying to do formal publication, which is going to take, many months, if not years, going to limit the ability for the data that you are sharing to actually impact the current crisis. Open versus subscription access, we deal with this. Authorship considerations, to what extent do the humanitarian workers who have been, fundamental to carrying out the research by providing the infrastructure necessary to carry out the research, to what extent should they be authors? What are the legal constraints if you're conducting research in a country where there's an oppressive regime that is the reason for the humanitarian emergency, such as a regime carrying out war crimes against its population? What if they pass a law saying that you can't publish research about them? And, there, at the very end of the day, even in sort of non-oppressive regimes, you get this question that comes up a lot around who owns the data. And in my experience, that question never leads to good results. It always leads to, endless conflict around how the data can be presented and published. And so that means that you need to really be able to think through these things in advance and ensure that even before you're conducting the research, you're thinking through the eventual dissemination and eventual questions around data ownership, et cetera. And then lastly, and perhaps the most important, is this issue of collaboration. In order to conduct research in humanitarian settings, I think you need these three different communities to come together: academic researchers, humanitarian responders, and local community members. And they all have to be part of the research, and they all have to be essential to it from beginning to end, from the inception to the dissemination. But these three communities are not natural partners. They don't speak the same language, either literally or figuratively. After the Ebola epidemic in West Africa, I published this sort of opinion piece in the journal Clinical Trials called "Academics Are from Mars, Humanitarians Are from Venus." And really, this article talked about the differences between academics and humanitarians in terms of the way they think about, what is success. A academic success is publishing in a highly ranked journal. For a humanitarian, they could care less about that. Success for them is getting, publicity and getting lots of donations for their work. So, and then the timeframes that they work in. Academics work on these really long timeframes of months to years, whereas humanitarians work on these short timeframes of weeks to months. If you have a humanitarian partner on your research, there is a high likelihood that they will no longer be employed for the organization that you're working with. They will no longer be employed by with that humanitarian organization by the time it comes around to publishing the data. And so how do you handle those differences in timeframes and bridge the gaps between these two communities? So I'm going to go through 4 different research studies that I was involved in that all relate to Ebola, but all look at it from different perspectives. The first, really more of an operational perspective. The second, more of a clinical trial. Third, more of a public health study. And fourth, more of a policy slash, really a political science slash sociology type study. And so all of these different research endeavors would be very important to responding to an Ebola outbreak in the settings where they occur. And each of them fill in different pieces of the puzzle, I think. So we'll start in West Africa in 2014 to 2016. So I was deployed with International Medical Corps in August of 2014 as part of their advanced team to respond to the Ebola epidemic in Liberia. Specifically, I helped them set up their first Ebola treatment center, their very first ever, in central Liberia, and then afterwards became director of their Ebola research team. And as director of the Ebola research team, we had one, very profound and difficult task, which is to make sure that everything we were learning about this, up until then almost unheard of disease was not lost when this epidemic was over, and that we could actually learn from it in order to provide better care in future epidemics. When I was helping open up the first Ebola treatment center, it was my job to develop International Medical Corps' first clinical protocols for managing Ebola virus disease. And when I turned to the literature, I found that there was absolutely no human research on Ebola at that time. There was not a single published study of any utility about the diagnosis, management, or natural history of this disease. Everything was based on anecdote, mostly anecdote from MSF workers who had responded to prior Ebola epidemics in the past. And yet here we were treating hundreds and hundreds of patients with Ebola at this treatment center and then 4 others that IMC opened over the next few months across Liberia and Sierra Leone. And so what we wanted to do is simply extract those clinical records. Seems like a very simple thing. Extract the medical records, digitize them, and just have a registry type database of all of the patients that we treated with Ebola and those that we managed who ended up not having Ebola, in order to better understand the natural history of this disease, how to diagnose it, and how best to treat it, what management strategies were likely to increase survival. However, the problem was that all of these medical charts were contaminated with Ebola, and all of them were slated to be burned to the ground along with the entire Ebola treatment facility when the epidemic was over. And so we had to go through a process of extracting that data, and that looked like a lot of different ways. Part of it was actually having duplicates of the chart and someone standing on the other side of the fence and an aid worker in full protective gear reading off information from one chart and then transcribing it onto another chart. As you can imagine, that is very time intensive and not very cost effective. Later, we started just taking pictures of the charts from across the fence. And then finally, we ended up having somebody go in with a GoPro camera strapped to their head, who was then able to take images of each of the pages of each of the medical charts. And then we could dunk the GoPro camera in chlorine as the person came out of the high-risk zone in order to sanitize it and then download the data from that. But that was only the first part of it. Once we had all these medical charts, we actually ended up with about 25,000 pages of clinical data on all of the patients that had been managed at these Ebola treatment centers. And we had to turn that data from these, clinical charts into an actual usable database. And so it was a lot of local data managers who are entering the data from these pages into a massive relational database that we set up in SQL. And then once we did this, we had to go through a process of quality checking, because all of that entering of data from physical charts into a database is going to be error prone. And nowadays maybe there are better ways to use artificial intelligence to try and capture that data and put it into a database, but we did this all by hand. And so we needed to do a double check. And so we did lot quality assurance sampling, which was able to show that, while not perfect, the data quality was pretty good across these different types of forms that we had. Overall, about 99.8% accurate. That sounds actually super good, but that still means there were hundreds and hundreds of errors because we had tens of thousands of data points basically in this database. We had over 400 variables on 2,500 patients. So it was enormous. But it allowed us to quickly start doing some analysis that was even useful within that current epidemic. We could start to actually see that while more men than women were presenting to our Ebola treatment centers, likely because they had better access to transportation, such as motorcycles, more women than men were actually testing positive for Ebola. And that has to do with the role that women played in households as caregivers, where they were the ones most exposed to the body fluids of other people with Ebola in their household. We were also able to identify the age groups that were at highest risk for death from Ebola, and it turned out to be children under 5 had the lowest survival, as well as patients over 45, while those in the in-between age groups tended to have higher levels of survival. And this helped us understand kind of how we could best prioritize care for patients, just even at a very crude level within our Ebola treatment centers. The other thing that we did is we developed the very first clinical prediction model, evidence-based tool for determining who was likely to have Ebola. Prior to this, there was a WHO algorithm that was not easy to use, and that algorithm had been just based entirely on expert opinion. There was no data involved in the creation of it. It was a handful of experts who said, we think this is the best way to determine who's likely to have Ebola. And that's a really important question, because when you set up an Ebola treatment center, you have a lot of people showing up. Some of them have Ebola. A lot of them have other diseases that look like Ebola, whether it be typhoid or malaria, or even the flu can look a lot like Ebola early on. And the last thing you want to do is admit somebody to an Ebola treatment center who doesn't have Ebola, because you are likely to give that person Ebola. And that can be perhaps the worst thing that one can do as a clinician. But the also other thing you don't want to do is discharge people home who have Ebola back to their communities to continue to spread it within their communities. And so you want as sensitive a tool as possible that's still reasonably specific. So we were able to use machine learning modeling with the data that we had from our patients who were presenting to identify sort of the best grouping of clinical signs that help differentiate people who had Ebola from those who didn't. And as you can see, the score that we created was pretty good at separating out those who were very likely to have Ebola, who had high scores, from those who were very unlikely to have Ebola, who had low scores. We also built an app using also machine learning modeling that could be used to help prognosticate people's chances of survival based on some very basic information you could enter in on arrival. And again, this could also be used to help prioritize care for those patients who were sickest and had the highest risk of mortality in a resource-constrained Ebola treatment center. We could also start to use this data to figure out what treatments actually worked for Ebola. So before this outbreak, we had absolutely no data on what worked or what didn't work. There was nothing. And there were all sorts of suggestions. In running this Ebola treatment center for International Medical Corps, my email was flooded every day with suggestions people had for how to treat Ebola, from very reasonable things to very crazy things like injecting their blood with ozone or giving them 10 grams of vitamin C or something like that. So we actually were able, this was not randomized controlled trial data, but we were able to use observational data. And specifically, we did some propensity score analysis to try and do our best to create comparative groups of individuals and look at how different treatments worked. One of the exciting things we found is that vitamin A, which is a very cheap and cost-effective treatment, was significantly associated with reduced mortality in our propensity score analysis. And this is something that can then be easily provided to patients. We were also able to find out exciting things that we may not have expected, but will be really important in Ebola epidemics of the future, such as environmental temperature increased mortality in patients with Ebola. As the temperature went above about a threshold of 27.4 degrees Celsius, mortality went up in patients. But we were able, and so you might say, well, this is sad news for a climate changing world, but what good is it for us in terms of providing better care to patients with Ebola? Well, it actually turned out that when we did subgroup analyses by the type of a treatment center patients were treated in, when they were treated in Ebola treatment centers with hardcover roofs, like tin roofs, that difference disappeared. And it only persisted in the patients who were treated in tents, these types of white tents, which are much poorer at reflecting the sun's rays and therefore become much hotter inside of them. And so you can build treatment centers that actually will reduce mortality in a hotter world in the future. And this was the first study to show that, only one, as far as I know. So we did a lot with this retrospective research. Retrospective research is great in humanitarian emergencies for another reason. We did not need ethical approval in advance for this study. We were able to collect all of this data, de-identify it, and then get ethical exemptions afterwards in order to do all of these different analyses. And in total, I've only showed you a few of them. We have published almost 20 papers just based on this data set alone so far. So that's great, but there are certain questions you can't answer definitively with retrospective observational data. In some cases, to really show that something works, you need a clinical trial. And as I mentioned, that is not easy to do in humanitarian settings for all the reasons I've discussed. But I also want to be clear that it's not impossible. And so this is probably one of the most exciting research studies I've ever been part of in my career. This was the PALM trial that was conducted between 2018 and 2020 in the Eastern Democratic Republic of Congo, an area that has been beset by conflict for more than 20 years, but has also been the site of the most Ebola outbreaks in history. Congo, unfortunately, has had the most Ebola outbreaks of any country in the world. And this outbreak that happened in 2018 was the second largest in history, second only to the 2014 to 2016 outbreak in West Africa. The number of confirmed cases was well over 3,000. The number of deaths was nearly 2,000 during this outbreak. But the difference is that this time the world was more prepared. Coming out of the West Africa outbreak, the World Health Organization and the NIH specifically partnered in advance with the National Institute of Biomedical Research in Congo and the University of Kinshasa School of Public Health and several different aid agencies in order to plan for and lay the groundwork for a future clinical trial in an Ebola context. And because they had developed these relationships, including relationships on the ground in advance, they were able to launch this study in record time. The outbreak began in August of 2018, and the study launched in October of 2018. And it involved this incredible collaboration between all of these agencies here that I've mentioned, including International Medical Corps. And so I served as the site PI for International Medical Corps' Ebola Treatment Center for this PALM trial. There were 2 other organizations, Alima and Doctors Without Borders involved, and 4 different drug companies, each of which had a drug that they thought, based on primate models, may be effective to treat Ebola, but had never been studied in humans. A few of these had been studied in phase 1 clinical trials in humans, but they had never been studied. I should say all of them had been studied in phase 1 clinical trials in humans, some in phase 2, but they'd never been studied in actual populations of patients with Ebola in a way that was able to show them as clinically effective. We had a huge issue when this study was launched in that one of the ethical dilemmas that arose is whether to have a control group that received placebo, which would be standard. The government of DR Congo, through its National Institute for Biomedical Research, pushed back heavily on that. They felt that it was unethical for a disease that had a essentially 66% mortality ratio to randomize patients to placebo. However, if we gave everybody one of these drugs and all of the drugs worked similarly, then we would not know if any of the drugs worked at all. And so that was the dilemma that we faced. At the end of the day, though, we listened to the local counterparts and we conducted the trial with 4 arms. Each arm had a different drug in it, but there was no placebo arm. And it was a high-quality, double-blind, randomized controlled trial with 4 arms, and these were the 4 different treatments that we studied. And we got super lucky because at the end of the day, 2 of the arms, Regeneron EB3 and MAB 114, these are 2 different monoclonal antibodies, had significantly reduced mortality compared to the other 2 arms. So we were able to say that these 2 arms worked, and that almost immediately after the Data Safety Monitoring Board viewed the data, they actually stopped the study a few months early because the data was so clear, and we immediately switched everyone over to getting one of these 2 treatments that was effective going forward. So we were able to actually change care even during this epidemic. And now these 2 drugs are FDA approved and approved by the WHO and available as treatments for Ebola and future epidemics. I will not go into details, but suffice it to say, the logistics for setting up a study like this were incredibly difficult. This study happened because of the incredible partnership that was set up and the massive amounts of money that the NIH poured into it. Otherwise, it would have never been possible. This was our checklist. In order to start the study at the Mangina Ebola Treatment Center that I was running, we needed to be able to have everything on this checklist checked green. And that included hiring and training our local study staff. And almost all of the research was done by local study staff because it was so difficult to get expatriates into this area, given the conflict. We had to have all of the forms set up. We had to have all of our equipment, the printers, the laptops, the software. We had to have a VSAT, which is a satellite, in order to actually connect the Ebola treatment centers to the internet because there was no internet there. So we had to have satellites set up at each of the Ebola treatment centers to be able to upload the data every day. We had to have the laboratory devices set up. We had to have all of the treatments, which were donated by the drug companies, but then we also had to have refrigerators and freezers to keep these treatments in. And when you have a refrigerator or a freezer, it turns out that you can't operate them when it's above 80 degrees outside. So you needed air conditioning to cool down the room in which the refrigerators and freezers were in. And in order to power that, you needed a backup generator, but not just a generator. You also needed a backup generator. And you also needed these fancy automated voltage regulators to ensure that the voltage going into the system was always even. There were 100 things on this checklist. And finally, we were able to check them all off again in record time and get the study launched. This was conducted in a conflict zone, and a conflict zone is not an easy place to conduct research. 2 of our research sites were actually attacked during the study and burned partially to the ground. Luckily, study staff were able to get all of the patients out of the Ebola treatment centers when that happened. And even more impressively, no data was lost, mostly because it was being uploaded by the VSAT every single day. So as mentioned, we were able to show that these drugs worked, and we were also able to show that mortality was even lower when treatment was given within the first 5 days. And it can be as low as 10% when one of these treatments is given within the first 5 days of illness, which is amazing for a disease that previously was killing 2/3 of the people who got it. The next research had to do with vaccination. And so during the West Africa outbreak, the very first trial of an Ebola vaccine had been conducted, and it had been shown to be very effective. Officially in that trial, 100% effective. Later trials have shown it to be probably about 90% effective or so, but still incredibly effective at preventing transmission of the disease. However, as we know, the most effective vaccine is not very useful if people are not willing to use it. And so with funding from the CDC, this was in DR Congo again, we conducted research during the 2018 to 2020 epidemic on what were the drivers of vaccine uptake and vaccine hesitancy in North Kivu, DR Congo, where this outbreak was happening. So we had a population that was experiencing an outbreak of Ebola and was being offered vaccination because we now had an effective vaccine, yet not everybody took up that vaccine when offered. And so we were able to study, by doing a study in this setting, we were able to help understand why that was. So our research methods, we had 28 local data collectors. We used Kobo Toolbox, which is commonly used in these types of settings as a data collection tool. We looked at 3 health zones in North Kivu, and we separately interviewed health workers and community members. And so this was a 2-stage cluster survey designed to capture people who are specifically offered vaccination. I won't go into all the detail of how we did that, but we randomly selected 438 health workers at 100 health facilities in these 3 health zones. And we randomly selected 631 community members from 39 randomly selected clusters. Because of the ring vaccination strategy that was used, the clusters were based around survivors of Ebola, because when when a person infected with Ebola was identified, then a ring vaccination strategy was used where everybody in that community who was surrounding that person was offered Ebola vaccination. And this was our results. So for healthcare workers, we found that 99% of those offered accepted it. And if you just looked at that, you might say there's no vaccine hesitancy at all in this population. Everyone took it. But actually, it turned out that the first offer uptake was only 70%, with an additional 12% at the second offer, 7% at the third offer, and 10% at the fourth offer, which brings up the point of how important it is to not just offer it once, but to offer it multiple times. Everyone who was a health worker knew they were at risk for Ebola, and so they understood the importance of this vaccine, but 65% were also concerned about the side effects that it had. Positive factors were older age, positive factors in terms of taking up the vaccine, being members of an Ebola response team, and then general vaccine confidence. And that shows up again and again. Negative factors were mistrust of the vaccine source or how it was produced, i.e. the fact that it was being brought in from outside the country, from places that people may not have trusted sort of reasons for wanting to send free vaccine to this country. Among community members, vaccine acceptance was lower. But again, if you look at first uptake, it was even lower. Less than half of those offered it on the first chance took it. And again, it wasn't because they didn't think Ebola was real. It wasn't because they didn't believe it was a problem. 90% believed Ebola was a serious disease, but 72% also, and 72% believed it could reduce its severity, but 64% believed it had serious side effects. And so understanding that people are not black and white about this, that they have these 2 strongly held opinions, and you've got to be able to work with both of those in terms of getting them to take up vaccine. So again, hearing positive information about the vaccine was a positive factor. Religion was actually also a positive factor, I think specifically because in this outbreak, the public health community worked with religious leaders to try and convince people of the importance of vaccination. And it shows just how important vaccination messaging from religious leaders can be, depending on the population. And also, when they heard about it from healthcare workers, family, and friends, they were much more likely to take up the vaccine, and traditional media sources, more so than social media sources, convinced them to take up the vaccine. And so this goes to show that despite, all of the interest in social media and how we can use social media as a public health tool, it comes down to when people are making this decision, it's those that they trust already, like family, friends, and their healthcare workers who are going to help them make this decision. I'll skip this piece. And so, these were some of the implications we learned from this study that I think could be helpful in future vaccination efforts for not only Ebola, but other emerging infectious diseases. Things like, if at first you don't succeed, try again. The importance of general belief in vaccination. And so this shows that increasing confidence in routine vaccination, like measles vaccination and polio vaccination, can actually be helpful in convincing people to then get vaccinated for these emerging infectious diseases when it arises. Understanding that people believe in vaccination but fear the side effects. Health workers and religious leaders can be trusted voices and should be incorporated in vaccination campaigns. Local vaccine production may assuage concerns about foreign vaccines. Building up local vaccine production in places that are likely to have these emerging infectious diseases, like DR Congo, could be helpful in the future. And managing security concerns that could prevent vaccine access is, of course, key. And that actually brings us to the fourth and last study, most recent one that I did. This study is specifically understanding civil-military coordination during public health emergencies. And specifically, we conducted this research in DR Congo related to the outbreak of Ebola in the setting of a conflict zone, as we've talked about already. There are a number of UN guidelines around civil-military coordination. This is how military actors coordinate with civilians, including humanitarian actors, during an emergency. And those guidelines don't mention anything about epidemics or pandemics. They're really based on acute onset disasters like earthquakes or conflict situations. Public health emergencies occupy a special place. They have unique issues which are going to be different from the considerations in a acute onset disaster or in a conflict by itself. They're protracted and dynamic in their nature. Risk communication and community education is critical in these settings to reduce misinformation. There's often a whole of government approach where governments are using their military in some way to respond to the public health emergency. We know from data on the COVID-19 pandemic, for instance, that more than 2/3 of countries in the world use their military to respond to COVID-19 in some way. And there may be an important tension between public health goals and humanitarian principles. The goal of stamping out the virus at all costs may come into conflict with the goal of ensuring humanitarian principles, such as the separation between military and civilians in conflict settings. So we wanted to look at the practices that have been implemented to overcome coordination barriers between civilian and military actors during humanitarian operations. And perhaps most importantly, what are the perceptions held by crisis-affected communities interacting with the receiving assistance from military/security forces and humanitarian agencies? How do the affected populations feel about military, for instance, being involved in managing the pandemic or epidemic? We actually conducted the study in 3 different contexts, including Syria and the Philippines. I'm not going to talk about those other 2 contexts, just going to talk about DR Congo. We did 175 interviews with military, humanitarians, and affected community members. We used standard qualitative analytic methods, including coding of the transcripts using grounded theory, developing memos based on the different transcripts, and then thematic comparison across different types of actors who we interviewed. We got ethical approval, both locally and internationally, and worked to mitigate the risks, most of which were related to security access, but also the fact that by the time we were doing this study, COVID-19 had spread through Africa, and we were facing COVID-19 risks in addition to security risks in DR Congo. So I won't go into a tremendous amount of details here about all of the specifics. I'll just kind of give some of the high-level results. A lot of humanitarians felt it was problematic the way that the Ebola response was managed in DR Congo because it pushed aside humanitarian principles and furthered community mistrust. There was concerns about sexual exploitation and abuse by some of the military actors as well as humanitarian actors who were involved in the response to the Ebola epidemic. In order to ensure they were able to access communities, a lot of the WHO teams used cash payments to armed actors to provide security for their teams as they went out to vaccinate in some of these very hard to reach communities. Though a number of humanitarian actors did feel that the armed actors provided crucial security that allowed the Ebola response to be successful. And many also referenced state sovereignty. It was the decision of the government of DR Congo to use its army, and that the humanitarian actors had to respect that. These were some quotes that we took, both positive and negative, from humanitarian actors regarding the role of armed actors in the response. From the perspective of security actors, there were concerns around coordination. Security actors like things to be very top-down. They like hierarchies, and they found the UN system and the humanitarian system to be very discoordinated and disturbing to them when it came to trying to figure out what their role was and how they were supposed to operate. And in particular, there were questions around duplicate command structures within the UN between WHO and the UN. Perhaps most interesting, though, were the results from community members. I'll kind of finish with this. There was actually a really significant diversity in perspective from community members on the use of armed actors. That ranged from concerns about human rights violations by certain armed actors and instances of violences in community that they witnessed themselves, to others who had positive associations. And this included some positive associations with the non-state armed groups, particularly the Mai Mai militias, which many community members actually sort of looked at not as a terrorist group or a negative factor within their communities, but sort of like a National Guard, like a local militia that was protecting their communities. And they reference many times where the Mai Mai militia actually supported the Ebola response in various ways. And in particular, this portion of DR Congo did not agree with the government that was in power in Kinshasa. And for them, the military from Kinshasa was almost as bad as the other armed actors that it was fighting in DR Congo. And so for them, the involvement of national military was actually a negative thing, but they supported the involvement of these local militia groups. And a significant number of respondents also spoke to the need to better engage communities and focus decision-making at the most local level. I think what comes out of this is understanding that if you want to provide security in these types of settings, conflict-afflicted settings, which are the exact types of settings where we're going to see lots of outbreaks in the future of emerging infectious diseases, we need to meaningfully engage the crisis-affected communities first to understand how they feel about different types of actors delivering assistance and who's going to be the best interlocutor for them. We need to integrate the ongoing policy evolution, especially on localization and gender and decolonization, into some of this humanitarian military relations discourse. And then investing in high-level diplomatic organizational engagement to prevent some of this duplication of roles and confusion that existed on the ground. And then particularly one of the things we're working on now is how we can adapt current guidance on humanitarian military relations to the specific challenges of epidemics and integrate some of this evidence base that we've collected into these policies, such as the Oslo guidelines on the use of foreign military and civil defense assets in disaster relief. All right, I am at my end, so I'll take any questions that people have here.
Well, that was a super whirlwind, fascinating talk. And also, like, for me, like, one thing I took away was that you span all the research methodologies, right? So there was a lot of mixed methods research here as well, which I think is just really important to highlight because we tend to focus on the quant, but the richness really came from the qual. What questions do we have from the group? And it was great that some of you were able to join us.
Yeah. And I'll just say that, humanitarian emergencies are an interdisciplinary field by its very nature. It's not enough to have the medicine right. You have to have the public health piece. You have to have the political piece, the sociologic piece, the gender piece, the engineering piece in the design of everything from how you build a Ebola treatment center to how you structure your water and sanitation. All of those perspectives need to go into the research that you conduct if you want to actually impact and improve the delivery of humanitarian assistance.
Thanks, Adam. Any questions from the group? Okay, next month, we have Adam Layton talking to us about quality improvement data registries and the initiative from Oxford University that has this ICU registry in multiple countries, which, given that emergency care often includes critical care and is not a venue-specific service delivery, we thought it'd be interesting for this group. Again, using retrospective, already existing data. When Lee Wallace came to speak in January or February, I think a lot of people weren't able to make it because you had boards. That was our mistake. But if folks do want to hear from WHO about the WHO Essential Emergency Care Toolkit, then we could invite him back in June. So just raise your hands if you would like us try and invite Lee back. I do recognize that the group seems to be waning as your fellowships come to an end. Anybody have strong opinions? Any opinions? Okay, we'll follow up by email. I'm not seeing anything either way. And then this will be the last time you'll probably see me because next time my colleague Amelia Poussin will be moderating and I'll be on leave. And then we're going to hand this series back over to the Fellowship Consortium, but hopefully folks can still make meaningful contributions and continue the efforts. Thanks, Adam. So great to see you. Really appreciate you joining us today.
You Bhakti. Take care.
Will do. Take care. Have a good day, everybody.
Thank you. Bye.